All right, welcome back. This will be your video lecture for Chapter 37, Head, Brain, Face, and Neck Trauma. Hope everybody's doing good. Introduce the chapter. So this chapter, we're going to talk about being an advanced EMT, identifying traumatic brain injury by evaluating the mechanism of injury and assessing patient for signs and symptoms of injury. Significant trauma to face can occlude airways and cause profuse bleeding into the airway, compromising the airway's patency, and be sensitive to patients. Okay. Do not lie to patients if asked about the potential for scarring or disfigurement. Be tactful and supportive. Injury to the neck, especially to the trachea or larynx, can be life-threatening due to airway obstruction. Let's review the AEMT of this. The skull, part of the skeletal system. Function of the skull is to protect the brain. The cranium, the large plates of the bones fused together. You have the frontal, temporal, parietal, sphenoid, occipital, and facial bones. We have the orbit and the nose, the maxilla, the zygomatic bones, and the mandible. Basilar skull is the floor of the skull. It occupies about 85% of the total space within the skull. The brain does, anyway. The remainder of the space is the cerebral spinal fluid and volume of blood. The brain itself, cerebral spinal fluid, serves as a cushion, surrounded by three layers of meninges. Three parts: the cerebrium, the cerebellum, and the brainstem. The cerebrium is where cognitive function, sensory function, and motor function, along with emotion. The cerebellum is coordination and equilibrium. And the brainstem, which has the pons, the midbrain, the medulla oblongata, the autonomic body functions, blood pressure, heart rate, respiratory rate. An injury to the brainstem, obviously not going to be good. And it can lead to that circulatory, respiratory failure, and yes, even death. Here we have a figure of the brain. It shows the cranium, the dura mater, the arachnoid, the pia mater. If we look at the neck, the structures that are vital to sustaining life, we have the trachea and the larynx. Obviously vital to air exchange. Major blood vessels that transport blood to and from the brain. The face contains 14 facial bones. The orbits around the eyes, the nasal bones, the zygomatic bones, and the maxilla. Most facial bones are immovable. They provide protection for the eyes. The function, anyway, that's the facial bones, and the function is, providing protection. The actual form, the face work of the airway and face. And it says significant trauma that causes fractures of the face may also cause brain injuries. And then we have a figure of the facial bones. We look at the eye, it's a global spherical shape, 1 inch in diameter. The outer layer is known as the sclera. The cornea is a clear covering over the front, and it covers the pupil. The iris is a colored portion. The iris dilates and constricts to change size of pupil to let in more light or less light. The lens focuses light entering the eye onto the retina. And then the retina itself, light-sensitive optic nerve, receives impulses sent to the brain. Within the brain, impulses interpreted as an image. That is so cool. How it receives all that information like that and forms an image. It's just crazy. 2 fluid-filled cavities, the aqueous humor and the viscerous humor. Again, 2 fluid-filled cavities, the aqueous humor and the viscerous or vitreous humor. Viscous vitreous humor. Surrounded by cup-shaped orbits formed by facial bones, and then the muscles attach eye to orbit and allow for movement. And then here we have the anatomy of the eye. An image describing that. General assessment and management of signs, altered mental status, bleeding, substantial edema or discoloration. Often patients will have complaints of pain and swelling of the affected area, maybe loss of function of the affected area, dizziness, headache, nausea, vomiting. Again, don't let the dramatic appearance of a head or facial injuries distract you from your primary assessment. Always make sure that airway is clear. In severe cases, endotracheal intubation or cricothyrotomy is necessary. In certain occasions, but if you run into those problems where if you have a lot of swelling and edema, things in the airway, it becomes very difficult to do those. And crics are very rare. Consider the need, for ALS, absolutely, but don't delay transport in your trauma patients. If it's an open wound, you're going to control the bleeding just like you've been trained already. If the patient's critical or there's substantial MOIs present, please expose the patient. Perform that rapid trauma exam. And then a more focused exam for isolated injuries. Sample is important and part of your secondary assessment if you can obtain it. And the usual reassessment, 5 for critical, 15 for non-critical. Let's look at injuries to the head, the scalp injuries. I guess the number one thing about scalp injuries is they're very vascular. They bleed oftentimes profusely, which can lead to hypovolemia. A scalping injury is defined as a large flap of scalp, hair, skin, underlying soft tissue. It's more of just a large avulsion. These can lead to a closed scalp injury from blunt trauma, may result in formation of a hematoma. You always want to consider if there was that much force to cause a scalp injury, that energy could be directed inside the brain or inside the skull. If we look here, the skull is a thick plate of fused bone. Its function is to provide protection to the brain. It can be fractured at times with forceful impact. Also, if again we're looking at the energy is enough to fracture the skull, we have to suspect maybe an injury to the brain as well. Not only to the head, not only to the brain, but also a cervical spine injury. We would treat for that just because of that high MOI. A linear skull fracture is a thin line fracture across bone on X-ray, no obvious deformity of the skull. It does not result in displaced segment of the bone. That's a linear skull fracture. Let's look at depressed skull fracture. It's an impact that results in multiple cracks pushed deep into the skull. If we are looking at a closed skull fracture, obviously the scalp remains intact, and then the opposite for an open. Penetration injury If present, immobilize impaled object in the skull and do not remove. There's a figure of the types of skull fractures listed here. Shows a linear, depressed, an open, and an impaled object. If we look at a basilar skull fracture, this is a fracture to the base or floor of the skull. Clear or bloody fluid drains from the ears, nose, mouth in patients with trauma to the head. And then we would suspect a CSF we would suspect that fluid to be CSF. We have raccoon eyes, and this is just bruising around the eyes, or battle signs. That would be bruising behind the ears. Those two are indicate a basilar skull fracture. One of the problems with the skull is it does not expand. It will not tolerate any type of swelling inside the skull. That blood will accumulate and it will increase intracranial pressure. Primary brain injury, the time of impact with the skull is important. A secondary brain injury is when the brain begins to swell. It may swell slowly. It may take a couple of days for it to really swell to start increasing intracranial pressure. If it happens, that brain tissue becomes ischemic and leads to hypoxia of the brain tissue. Cerebral edema and increased ICP. Brain tissue is compressed by that. Progressive brain dysfunction. You will have all the altered mental status that comes with that. Patient may complain of a headache and also projectile vomiting. Unequal pupils. So Cushing's reflex is something to really understand here. Increasing blood pressure with a decreasing heart rate. Cushing's triad, Cushing's reflex coupled with an irregular breathing pattern. Cerebral edema, an increased ICP, increase in blood pressure worsens intracranial bleeding and cerebral edema. Corrected by decreasing ICP with surgical intervention and medications. A herniation is defined as tissue forced through sutures within the cranium. Those are those lines on the cranium. Signs of herniation. You'll have Cushing's triad, pupillary changes, altered respirations, trismus, posturing in response to painful stimuli. All of those are signs. We have decerebrate posturing and decorticate posturing. Decerebrate posturing is the rigid extension of the extremities in response to painful stimuli. And decorticate is rigid flexion of the upper extremities in response to pain. We can look here, and this exhibit shows this. The first one, A, shows decorticate posturing. And I just remember that the decorticate, or the core of the body, is where the arms come up to. And then if you look at decerebrate, it's more of the extension away from the body. Traumatic brain injuries, or TBI. Consider restricting motion of the cervical spine. Keep the airway open. Ensure ventilations are normal. If needed, administer oxygen and obviously control bleeding. So, maintaining MAP with cerebral edema is critical. We don't want that blood pressure to be too high. We want it to be in a normal range. to help manage that intracranial pressure. Patients with TBI should receive IV fluids to maintain a blood pressure of 90 systolic. Again, if they have a good blood pressure, you can start your fluids. You can do a KVO. They could be there in case you need them, but we do not want to increase blood pressure that will harm intracranial pressure. You want to ventilate the patient to remove excess carbon dioxide. So if you look at it, high carbon dioxide causes vasodilation, and low causes vasoconstriction. So we don't want this patient to have a lot of carbon dioxide. We want this patient this is a patient that you would consider hyperventilating to reduce CO2 content. Increased perfusion of the brain accompanied by adequate blood glucose levels. So IVs only if necessary. Maintain a body temperature. Check your glucose levels. You would treat any type of hypoglycemia, and it goes without saying to transport without delay. So when we talk about the key components of the neurological exam, we want to determine if the history of the altered mental status or loss of consciousness after injury. Because that's a big deal, because a lot of these patients have a brief LOC. It'll be very brief, but that increases their chance for a TBI if they have if they're positive for LOC. You want to assess the level of responsiveness and their mental status. Check their pupils for size. Make sure they're equal and reactive to light. And you want to look for those neurological deficits, meaning their grips are unequal. They have stronger response on the right side. Their left side appears maybe a little bit weak, or the opposite. The right side is a little bit weak and the left side stronger. If we look at concussion, this is a brain injury caused by blunt force trauma. There is no structural damage to the skull itself. Post-concussive syndrome, patient experiences headache, may have memory problems or depression, and this can occur in conjunction with other TBIs. Cerebral contusions. This is an actual bruising of the brain tissue with prolonged loss of consciousness or confusion. Edema to the brain is definitely a concern. We have the coup contra here, injuries where the brain actually bounces back and forth off the skull. And so here is a image of the coup contra coup, where the brain slams forward to the skull and then slams backwards on the back side of the skull, or the back side of the brain itself. So signs and symptoms of a TBI: altered mental status, weakness, seizures, a unequal respiratory rate or pattern, bradycardia with hypertension, impaired speech, unusual behavior, unequal pupils, nausea, vomiting, posturing. All of these are signs of a possible TBI. Specific brain injuries: a diffuse axonal injury caused by shearing or tearing forces associated with acceleration, deacceleration injuries. The prognosis for these patients are usually very poor and can be associated with shaken baby syndrome. Specific brain injuries: intracranial hemorrhage, bleeding with cranial vault resulting in a hematoma. So we have the epidural hematoma, the subdural, subarachnoid, and the intracerebral. The epidural is between the skull and the dura mater. It's probably the easiest to resolve in a surgical procedure because as soon as you open the skull, the hematoma can be reduced. The subdural, this is between the epidural and the dura. This is a little more complicated because now we have to go through the top portion of the brain to reach the middle portion, if you would, to reduce that hematoma. So the subdural is actually between the dura mater and the arachnoid mater. A subarachnoid between the arachnoid and pia mater, and intracerebral is within the brain tissue itself. We have here, it shows a picture here of the dura and the epidural hematoma that's above the dura. Here we have the image of a subdural hematoma. This just shows it's where it's located in between the epidura and the dura. And this is an image of just an intracerebral hemorrhage. So injuries to the face, it can be very frightening for the patient. There could be a temporary or permanent loss of vision, a permanent disfigurement. Your primary concern here is the airway. Fractures of the mandible are extremely painful, and they can result in airway compromise. It's going to define now a Le Fort 1 fracture, and this involves the maxilla only, and may result in slight instability and deformity. A Le Fort 2 fracture is a maxilla and nasal bones. And a Le Fort 3 fracture is the entire midfacial region. Le Fort 2 and Le Fort 3 fractures usually result in leakage of CSF. Fractures to the nasal bone are not life-threatening. Again, airway is going to be your primary concern with these fractures. And then we have orbital fractures that involve the zygoma and the maxilla. This is a figure that shows the fractures of Le Fort 1, 2, and 3. Eye injuries result blunt trauma, penetrating trauma, or chemical exposure. A detached retina is force applied to the eyes great enough to cause separation from the retina from the wall of the eye. This is a true emergency, and the patient may complain of dark areas within their vision. Penetrating trauma places the patient at risk for blindness. The extent of the injury is going to be directly related to the MOI. Stabilize impaled objects in the eye, and removing them, just like with any impaled object, can cause additional injury. You never want to try to replace an eyeball in its socket. Here we have an image of a large subconjunctival hemorrhage caused by a blow to the right to the eye. It looks very wicked. Looks very bad. Eye injuries, impaled objects in the eye, are extruded eyeball. You want to hold a cup and dress it in place while you apply a bandage that encircles the head and covers both eyes. If the eye is extruded, apply saline moist dressing over the eye. It's important to cover the uninjured eye and transport immediately. Chemical burns can cause blindness. You may see redness or cloudiness of the eye, swelling. The patient may have blurred or diminished vision, pain, redness. You want to flush that chemical from the affected eye with water. If the contact lenses are in place, remove them. Here is an image of a chemical exposure to the eyes. Ear injuries, they normally don't pose a life threat. Avulsed teeth, consider teeth to be a potential airway obstruction, and transport the teeth with the patient. If we look at injuries to the neck, cervical spine, provide protection. The function of the cervical spine is to provide protection to the spinal cord. If the patient has blunt or penetrating trauma to the cervical spine, it could be a whole host of problems: paralysis, shock, respiratory compromise, or even death. Injuries to the neck, or we're concerned here about injuries to the blood vessels of the neck. Penetrating trauma to the neck, injuries to the carotid artery may result in life-threatening bleeding. Hematomas from closed injuries can obstruct airway or impair blood flow. We have to be concerned about air embolisms. The air enters the vessels of the neck. You prevent this by immediately covering the open neck wound with a gloved hand and a four-sided occlusive dressing. This is an image of a laceration to the neck. Injuries to the airway, injuries to the tracheal larynx affects airway patency. Frequently assess that airway. All right, that's it, y'all. I will post this and we'll see you in class.